Thank you, dear President, ladies and gentlemen, and the Jafron to invite me here. Thank you very much. My topic is the application of hemoperfusion in sepsis. Sorry about some overlap slides with the previous speaker, but it's unexpected for that, and we need more studies, and then some slides may be same. In my talk, I'll tell you briefly about the pathophysiology of sepsis and the indications in ICU and the hemoabsorption, what's it, and the hemoabsorption using sepsis. The definition is the key point that the complex clinical and biological syndrome defined as life-threatening organ dysfunction caused by dysregulated host response to infection. Because of that, the new therapies have been developed as for address certain steps of this immune dysregulation. If you look at the pathophysiology very briefly, the host and pathogen interaction is important. When it starts, there are two arms, that the pro-inflammatory response or anti-inflammatory response. In pro-inflammatory response, there is excessive inflammation and causing to tissue damage. At the anti-inflammatory phase, there is host susceptible to secondary infection due to immunosuppression. In the pro-inflammatory phase, the PAPs and DAMs affect the system, and they induce leukocytes, and because of the activation of leukocytes, there is complement activation, there is coagulation cascade activation. At the other side, there is impaired immune cell function, which causes impaired phagocytosis or maturation defects, and it causes apoptosis in the cells. The immune response in sepsis is excessive and unbalanced host immune response, and that's why we have to do something for this and stop in any time any steps in sepsis to be successful to treat sepsis. The DAMs and PAMs activated neutrophil, and then they cause the release cytokines. The inflammatory and anti-inflammatory cytokines releasing. If it's excessive, it's called cytokine storm, and it causes immune suppression and also organ-related dysfunctions, like in brain, sepsis-induced encephalopathy. In the vascular system, the vascular hyperpermeability causes glycocalyx disruption, impaired cell-to-cell junction. Also in heart, cardiomyopathy or impaired tissue oxygen metabolism, and causes microvascular system disorders. There's a vicious cycle that due to DAMs and dysregulated immune response, the cell death, tissue injury, apoptosis, and DAMs, the high mobility GOL-BAX1 protein increases, and then the DAMs effect again and again, the circus vicious is going on. And if you look at the immune steps or events in sepsis, there is also a possibility effects of the gram-negative and gram-positive results, and they cause at the end microvascular occlusion and vascular instability, and the end point is that the coagulopathy, fever, vasodilation, and capillary leakage, and it causes sepsis and multiple organ failure. If you look at the right side, the hyperinflammation and immune suppression is very important, and then early deaths, you can see that in the early phase, due to initial intense inflammatory response is 10%. If you can affect here, if you restore the hemostasis, and the recovery is up to 60%. That's why important, I will tell in my forward slides also again. And the blood purification targets are removing the pathogens from the blood. The second point says removing endotoxins or other PABs, and removing leukocytes and reprogramming leukocytes, or reducing cytokines in blood levels. This cytokine absorption is important, and as you see here, how can I use the touch laser here? Okay, no? Okay, the pro-inflammatory cytokines, TNF-alpha, IL-1, IL-6, IL-8, okay, thank you. Here, and the indications for hematabsorption in ICU are sepsis, intoxications, hepatic failure, the non-infection hyperinflammatory phases like conditions trauma, pancreatitis, burn, or rheumatological disorders. My topic is specifically for sepsis, and I will talk for this sepsis now. The different mass separation processes are diffusion in hemodialysis, we know that, the convection in hemofiltration or hemodiafiltration, and the solute absorption, the mass separation by solid agents like sorbents, we can use that. And the sorbents are very large surface volume ratio and the significant capacity to bind specific solutes like with weak ionic bonds, the van der Waals forces, or strong hydrophobic bonds, and they produced in granules, beads, or fibers. The hemoperfusion in sepsis can be selective or non-selective treatment. The selective treatment is selecting the targeting the key molecule special for endotoxin. Mainly, extracorporeal treatment is an adjuvant therapy. It's a rescue therapy. It's a salvage therapy in sepsis. And the main goal of constructing an optimal sorbent cartridge is to obtain the maximum contact of the fluid phase with the entire amount of the available sorbent. There are three phases is that here, as you see here, in the interparticle phase, the blood flow through the tortuous pathway. In the interphase phase, the blood flow on the external surface of the bead, and the intraphase part is the blood flow on the internal part of the bead. The current available technologies are here. As you see, there are sorbent polymer differences in there. There is Nordic charcoal, polymyxin B, spherical charcoal, or polystyrene, divinyl benzene, or ultra-high molecular weight polyethylene beads with end point attached heparin. They're all different each other. And the cytokine in sepsis is important. The profile, if we check this, the IL-6 and organ dysfunction is very with an interaction. And if you look at the in Kuma study, the IL-6 in survivors and non-survivors, the right side is for male and the left side is for female. In male and female, in survivors, the IL-6 level decrease, and in non-survivors, there is no change or they increase. And another study in Tchaikovsky study, the procalcitonin, interleukin, and CRP levels are very high in non-survivors due to sepsis. There is selective hemoperfusion with a fiber column immobilized with polymyxin B. And in this trial, the EUPHASE trial in 2090 with 64 patients in septic shock due to intra-abdominal gram-negative infection, and 34 patients used polymyxin B30 not, and improvements of the hemodynamics, respiratory function, sepsis-related organ scores, and mortality in treatment group. And there is also a decrease in 28-day mortality from 53 to 28. But the second study with more patients, 450 patients in septic shock with increased high level endotoxin, the polymyxin hemoperfusion for 90 and 120 minutes, the polymyxin hemoperfusion did not show any significant reduce in mortality in that study. In non-selective hemoadsorption, as mentioned before in the previous speaker, there is sorbent, we use hemodiafilter, and we have opportunities to use alone the sorbents or combine with the CRRT or ECMO to use together for effectiveness. In this study, there is cytokine elimination for rescue therapy, 20 patients with refractory septic shock. In conventional therapy, the lactate increase and the high dose vasopressor necessary noradrenaline 0.3 microgram per kilogram per minute. 6 hours after conventional therapy, there was hypercytokinemia, and IL-6 level is high in that group, and the hemoperfusion treatment initiated approximately in 8 hours after the shock treatment. And when you look at the noradrenaline requirement, it decreased with the hemoperfusion use, and the lactate clearance increased in that patients. And another study here, the cytokine elimination causes the shock reversal, and 28-day mortality is 45%. In Jafron neutral microporous resin, which is strain divinyl benzene copolymer, there are 3 different types, and HA130, 230, or 330, 380. There are different indications. In 330, it's my topic now with sepsis, the acute conditions with cytokine storm such as sepsis, we use it, and the molecular weight removed is 10 to 60 kilodalton, and the resin pore size distribution is 500 dalton to 60 kilodalton. The toxins removed here, the cytokines complements removed by this 330. If you look at this, the electron microscopy results here, the beads, the surface of the beads at the middle, and the pores you can see. In that study, in 3 septic children, they use HA330, 4-hour treatment with 330, and they found that the IL-6 level decreased here, as you see, very, very significantly decreasing. Huang study for 44 patients, 24 patient treatment group and 24 control group, they use HA330, and the etiology of infections are mostly abdominal, the microorganism gram-negative bacteria mostly, and in that group you see that the dose of dopamine, dobutamine, and noradrenaline use decreased in HA330 group. And if you look at the IL-6 levels here, IL-6 levels decreased in HA group here, and no significant difference or decrease in control group. This in this study also we can see the ICU mortality is significantly reduced in the HA hemoperfusion group when we compare with the control group, and the hospital mortality decreased in the hemoperfusion group. The same authors has another study 3 years later, published with 46 patients in sepsis and acute lung injury patients, and they use HA330 versus usual care. This is for 3 days treatment, and in that study, IL-1, TNF-alpha, and levels decreased in plasma and in bronchoalveolar lavage control, and also dopamine, noradrenaline requirement decreased in hemoperfusion group. And also ICU mortality and 28-day mortality has difference in hemoperfusion group in that study. This is the comparison of the two studies with the same study group here. And this is another study by Chu, 30 patients in septic shock. They use hemoperfusion with pulse high volume hemofiltration. And the other group is only with continuous venous hemofiltration. They compared this T group in hemoperfusion with high volume, pulse high volume hemofiltration. There is a significant decrease in procalcitonin, Apache 3, and decrease in SOFA score. It means it's better condition in the patients, and also IL-6, TNF-alpha, and IL-10 levels decrease in the first group. This is another study from Turkey. This is the first study in Turkey, 2019. They used, for 11 patients with high dose vasopressor organ, and they found that the hemoperfusion group, the CRP and procalcitonin level decreased. This is another case report for 78 male patient, fecal peritonitis in septic shock. In this patient, they saw that the noradrenaline use decreased, blood pressure increased. This is our case, one of our case, 31 years old female. She had bariatric surgery. In the postoperative 7th day, she had septic shock due to a surgical problem. There is source control for reoperation, and we saw that there is a leakage. And at the 3rd day ICU admission, we used HA330, and she became in a good condition, but 20 days later, due to induced pneumonia, she had another septic shock attack, and we used again the hemoperfusion, and we have the same results: decrease in noradrenaline use and increase in blood pressure. At the end we are very happy because she's well and discharged from ICU. I skipped this. And in septic shock patient, if there is refractory septic shock, multi-organ dysfunction, we can use high endotoxin activity. If there is hypercytokinemia, we can use consider cytokine absorption. And the important point is that in sepsis, the timing when we have to start to use it. I think that this is domino effect. If you couldn't stop it at the beginning, you can't stop to drop all the domino stones. Because of that, you have to do this in this phase, earlier phase, to restore the organ perfusion. In sepsis guideline, it says that there is insufficient evidence. We have to improve the data for this. For the future research, defining the adequate dose, optimal dose, and safety results. This is my last slide. Sorry for this. Hemoabsorption is a salvage therapy. It's a rescue therapy. It's not definitive therapy. You have to do everything for this patient, and you can use it. But most important point is right time, right patient, and right screening conditions. I couldn't do this for this movie. Okay, slide videos.
Thank you very much.
Thank you.